Hello, my name is Diah Switari, student number 173 from small group discussion B5. In today's video, we would like to present our student project with the topic Fluid Management in Pediatric Resuscitation. Here is the list of names of our group members. And before we jump into the main explanation, I would like to explicate the background or context of our student project. Okay, so it is well known that water is crucial for cellular homeostasis. It plays a huge role in tissue perfusion, which is the main goal of fluid resuscitation. Pediatric resuscitation management is said to be quite tricky because medical staff need to use a variety of age-appropriate physiologic parameters. Children's physiology of dehydration, presentation, and shock is quite different from adults. This is due to children's ability to compensate for significant volume loss much longer than adults because they have higher cardiac reserve. Thus, their vital signs may appear near age appropriate despite ongoing fluid loss, which is not a good thing. Overall, intravenous fluid administration is required as soon as possible and should be targeted toward perfusing critical organs. Considering there are some specific requirements in pediatric emergency, and how difficult it is to accurately evaluate varying degrees of dehydration with pure reliance on clinical examination alone, it has triggered increasing investigation of current beliefs, and we would like to explain further about fluid management in pediatric resuscitation. So here are the formulation of problems and purposes of our student project. And the benefit of our student project is to provide a better understanding and explanation of fluid management in pediatric resuscitation.
I'm Luhkomang Ayun Lafiwanda, NIM 133. I will explain about the physiology of fluid regulation in pediatrics. Body fluids is divided into two compartments. There are intracellular fluid, which accounts for 2/3 of total body fluids, and extracellular fluid, which accounts for 1/3 of total body fluids. 2/3 of the ECF is interstitial fluid. Another third is intravascular fluid or plasma, and the remainder is transcellular fluid such as peritoneal fluid, synovial fluid, cerebrospinal fluid, and intraocular fluid. Water plays an important role in homeostasis, waste elimination, transport of nutrient and other substance into cells, maintaining normal body temperature, and as a carrier and a solvent for various metabolic process for cell growth and functional activity. In carrying these roles out, it's necessary to have a body balance, which is regulated by the thirst mechanism and regulation by the kidney. Thirst mechanism. When water loss is greater than water intake, the body will be dehydrated both intracellularly and extracellularly. Intracellular dehydration results from an increase in the blood osmolality. This increase in osmolality activates two small structures located outside the blood-brain barrier. These two structures are subfornical organ and organum vasculosum of the lamina basalis. Activation of SFO and OVLT will cause thirst, which triggers the body to consume more water so that it can maintain the balance of body fluids.
Hello, my name is Rista Parabita Karamaya with NIM 170. Extracellular dehydration is a condition of decreased blood volume or hypovolemia, which is usually accompanied by hypotension. Hypotension is detected by special cells in the kidneys that causes renin release. Renin is an enzyme that converts angiotensinogen into angiotensin 1 or ANG1 in the blood, which will be broken down by angiotensin converting enzyme or ACE into ANG2 in the lungs. ANG2 causes vasoconstriction and release of aldosterone, which then increases sodium reabsorption, hence water uptake happens. Fluid balance regulation by the kidneys is also influenced by antidiuretic hormone or ADH and natriuretic peptide or NP. ADH is secreted by the posterior pituitary in response to increased blood osmolality during dehydration. ADH promotes water absorption. Meanwhile, NP has a diuretic effect and causes vasodilation. NP has antagonistic effects on the RAAS by increasing the permeability and filtration rate of glomerulus. Thus, to maintain a fluid balance, a balance is needed between the RAAS and natriuretic system. Thank you.
Hello, my name is Ferdinand with rigid number 108. So about the pediatric fluid resuscitation, if the pediatric patient came to the hospital in the emergency state, use the pediatric assessment triangle for the early recognition of a child in danger. Then follow the ABCDE, like airway, check and maintain the patient airway. B, breathing, check the patient respiratory. C, circulation, check the patient pulse rate, pulse volume, capillary refill time or CRT, urinary output, level of unconsciousness, and many more. And D, disability, check the patient unconscious level with Glasgow Coma Scale. Based on the algorithm, pediatric fluid resuscitation have several steps. First, when the patient came to the hospital, we must check whether the child have abnormal perfusion with or without hypotension. Then give one or more only fluid, like bolus of 10 milliliter per kilogram, if the patient with recognized shock. Then repeat the fluid boluses up to 40 until 60 milliliter per kilogram in the first 1 hour until shock resolve or there is a sign of fluid overload. Reassess after each bolus and avoid repeated bolus. For fluid bolus, we can use balanced crystalloid as first choice, if available. If not, normal saline is an acceptable alternative, especially in the case of malaria or dengue fever. For children with sepsis, consider albumin as second-line fluid. And in non-hemorrhagic shock, blood transfusion are only needed when blood values fall below minimum value.
Hello everybody, my name is Lalita Samala with student number 156 and I'll tell you about the indication of fluid management in pediatric resuscitation. Fluid resuscitation therapy in children is often used to replace the acute fluid loss that can lead to hemodynamically unstable, for example in shock. Shock can be classified into four, such as hypovolemic shock, cardiogenic shock, distributive shock, and obstructive shock. Usually, the administration of this fluid resuscitation is given in emergency cases before taking the administration of other fluid therapy. This therapy is intended for rapid expansion of intravascular fluid, either due to excess R output or increasing capillary permeability so that fluid enters the third space and improving tissue perfusion. Other than that, the use of fluid resuscitation is to give supportive care for children who are acutely ill. The administration of IV fluid is required if the sufficient fluid cannot be provided through enteral administration. Oral dehydration has failed for several reasons, such as respiratory distress, a perioperative state, neurologic impairment, gastrointestinal illness, or dying due to an acute or chronic illness. This will make it more efficient to rehydrate it. Thank you.
Hello, my name is Putri Agnes Monica with number student 100. So let me explain about the types of fluid resuscitation in child. So there are two groups. First is crystalloid and second is colloid. For crystalloid, there are three types. First is isotonic crystalloid. So for isotonic crystalloid, the concentration of electrolyte is equal with the concentration of electrolyte in plasma. So the effect is minimal. For osmosis is minimal, and for the advantage is the crystalline lactate or isotonic crystalloid is cheap, easy to obtain and store, less reaction for allergies, and can be directly to overcome the hypoperfusion. And also it can use for liquid challenge test. And for the side effect, it can cause the peripheral edema and also pulmonary edema at large dose because of the isotonic crystalloid is easy to transfer from intravascular to interstitial. And second is the hypertonic crystalloid. So for the hypertonic crystalloid is more concentrated of electrolyte than the plasma intravascular, and it can cause the fluid attract into the intravascular place, so it can cause the hemodilution. And the advantage is the improved blood flow to vital organ, And from the side effect is hypernatremia and also hyperchloremia. And the last is hypotonic crystalloid. So for hypotonic crystalloid, the concentration of electrolyte is less concentration than plasma intravascular. And for crystalloid fluid, it's rapidly moved from the intravascular to the interstitial and cells because of the concentration.
Hello, my name is Pratista and my student number is 2237. So now I'm going to explain the types of colloid used in pediatric resuscitation. Based on the type of preparation, colloidal solutions consist of natural and synthetic colloid. The first one is natural colloids. Natural colloids are 5% plasma protein fraction and human albumin. In addition to albumin, deactivated prekallikrein or Hedgemann's factor fragments are present in the plasma protein fraction and often cause hypotension and cardiovascular collapse. The second type is synthetic colloids that are consist of dextran, hydroxylated starch or heta starch, and gelatin. Dextran is derived from glucose polymer molecules in large quantities. Dextran is produced to replace fluids due to increased weight of the molecule, so it has a long duration of action in the intravascular space. However, this drug is rarely used due to side effects and associated complications, which include renal failure secondary to deposition in the renal tubules, impaired platelet function, coagulopathy, and disorder of the blood cross-matching. Next is hydroxylatil. This colloid is potential as a large plasma volume expander with toxicity, which is low and doesn't interfere with coagulation. Then pentastarch is chosen as a colloid for large volume fluid resuscitation. The last one is gelatin. Gelatin solution is a urea or succinylated cross-linked modification of bovine collagen and can trigger hypersensitivity reaction.
My name is Anastasia Vanatrix Kusianto, student number 138. I will explain about the equipment used in fluid administration. Fluid resuscitation should be administered orally as long as it is possible. Oral fluid resuscitation usually used to treat mild to moderate dehydration. If oral fluid resuscitation is not possible, the first choice is using enteral tube, such as nasogastric tube, nasoduodenal tube, or gastric tube, or gastrojejunal tube. The last option is parenteral route or intravenous line. As seen on these pictures, these are the equipments used in parenteral route. The equipments for enteral and parenteral fluid resuscitation in pediatrics should be measured and chosen carefully. Thank you.
Hello everyone, my name is Putu Arya Radhi Bramantia with student number 181. Fluid management is critical when providing acute care in the emergency department or hospitalized children. Early and appropriate fluid administration improves outcomes and reduces mortality in children. Water is essential for cellular homeostasis. The human body has a strict physiologic control to maintain a balance of fluid and electrolytes. However, in disease states, this mechanism may be overwhelmed. Dehydration occurs due to the significant depletion of water and electrolytes. It commonly increases morbidity and mortality in children. The Holiday-Segar equation remains the standard method for calculating maintenance fluid requirements. Accounting for deficit when determining the fluid infusion rate is an important factor in treating dehydrated patient. Deficit fluid is generally administered over the first 24 hours of hospitalization. Hydration status can affect the dose needed to achieve therapeutic concentration, and dehydrated patient may be at risk for toxicity if standard doses of drugs with high volumes of distribution are used. The three steps in treating dehydration are as follows. First, correction of fluid deficit. This includes fluid loss. And second, maintenance therapy. This involves physiologic requirements of fluid and electrolytes. Third, sustained replacement of continuing fluid loss. The recommended rate is 50 ml to 100 ml per kilogram over 2 to 4 hours of oral fluids. It is recommended to use an oral rehydration solution rather than free water or a commercial sports drink. An isotonic solution should be administered for the correction amount of depletion, regardless of the plasma sodium concentration, and the fluid balance should be monitored in all children receiving IV fluids.
Hello, my name is Iwan Bagus Abagala Saputra with NIM 190251150. So today I will explain about target of fluid management in pediatric resuscitation, insight from latest theory. So the general target of fluid management in giving resuscitation in pediatric patients is to correct an acute hypovolemia or intravascular volume deficit. There is a conceptual model called as ROSE, which shows an accurate dynamic approach to fluid therapy that helps to maximize the benefits and minimize the harms of the fluid therapy. The ROSE approach consists of resuscitation, optimization, stabilization, and evacuation phase. The first phase, which is resuscitation, is focused on patient rescue and early adequate fluid management. So in order to achieve correction in shock patients to help rescue the patient, the perfusion pressure needs to be adequate and the fluid balance must be positive. Meanwhile, in the second phase, which is the optimization, the focus is on optimizing and maintaining adequate tissue perfusion and oxygenation to prevent further organ damage in patients who are still hemodynamically unstable. So the patients require careful monitoring and check their hemodynamic status. The third phase is the stabilization phase, which focuses on providing organ support or homeostasis and providing water and electrolytes as ongoing losses replacement in order to make a zero or slightly negative fluid balance. And lastly, the goal of the fourth phase, which is the evacuation, is to remove excessive fluid.
My name is Dias Boscoras, number 168. Complications of fluid management in pediatric resuscitation. Fluid resuscitation therapy in children is often done to replace acute fluid loss, which will lead to organ failure, as the body's vital organs lack perfusion in order to perform metabolism. A life-saving procedure to correct lack of perfusion and fluid imbalance, and its immediate goal is to prevent organ damage due to anabolism. Complications such as hyponatremia, fluid overload, or hypernatremia may occur in patients receiving fluid resuscitation therapy due to excess free water, over aggressive reperfusion, or inadequate water replacement, respectively. Hyponatremia is defined as plasma sodium concentration which is less than 135 MEq per liter. It may occur in children receiving intravenous fluid replacement, moreover with the use of hypotonic instead of isotonic fluid. It is a common occurrence where there is a deficit of sodium or excess free water due to the excessive ADH release. Fluid overload is the accumulation of fluid leading to positive fluid balance or volume overload. Hyperaggressive reperfusion with excessive fluid and sodium results in increased volume retention, exacerbated by children with chronic comorbidities and metabolic disorders. Assessing the signs of fluid overload such as excess weight gain and edema is vital. Hypernatremia is a plasma sodium concentration of more than 145 MEq per liter. It suggests the occurrence of water loss instead of sodium change, generally occurring with sodium deficiency despite the elevated sodium concentrations due to higher loss of solvents. Infants in particular are at risk of inadequate water replacement occurring due to diarrhea or poor breastfeeding. Thank you.
My name is Safina Gisitandi, name 040H. So, for the conclusion, there are 10 points of this topic. Fluid regulation in pediatric is different from adult. A, B, C, D, E is the first thing to do in pediatric emergency. A, B, C, D, E is airway, breathing, circulation, disability, and exposure. In shock patient, the early fluid management is bolus of 10 ml per kilogram, then repeat up to 40 until 60 ml per kilogram in the first hour until shock resolve or there are signs of fluid overload. Blood product given in the cases of hemorrhagic shock. Fluid resuscitation in children is given in emergency cases to replace acute fluid loss in hemodynamically unstable patient. Another indication of fluid resuscitation in children is to give supportive care for children who are acutely ill. Crystalloid and colloid are the major group of fluid type used in pediatric resuscitation.
My name is Ayuni Putriadini, student number 141. The next conclusion are crystalloid is the first option in mild and moderate fluid deficit, and colloid are used in patients with severe fluid deficit or in patients with loss of large amount of protein. Fluids should be administered per orally as long as it's possible. If it's not possible, the other options are enteral and parenteral. Three key steps in fluid management are correction of fluid deficit, maintenance therapy, and sustained replacement of continuing fluid losses. conceptual model about target in fluid management, known as ROOS, R for resuscitation or salvage, O for optimization, S for stabilization, and E for evacuation. The last one, complication of fluid administration, are hyponatremia, fluid overload, and hypernatremia. So that's all from STDB 5, and these are our references. Thank you.